to participate in the conference. It's really honor to be with you. My topic is different. It's about pelvic floor rehabilitation. I'm a consultant in Alexandria University in Egypt. I was with you in last year in London, and I talk about the same presentation. I'm a consultant of pelvic floor presentation. It's about obstructed defecation in elderly person and the role of pelvic floor rehabilitation in this condition, because we have many patients in our country, especially Arab countries, and it's a hidden topic. This topic is talking about the role of pelvic floor rehabilitation in elderly patients with obstructed defecation. To define obstructed defecation, it's not like the normal organic constipation. It's a type of functional constipation, which means that there's a problem in emptying of stool in spite of soft motion. The patient is suffering from incomplete defecation or difficult defecation in spite of, and he has the desire, but he can't pass the soft motion. The incidence is unknown because it's taboo. It's a hidden problem because it can lead to fecal incontinence at the end and sexual problems, as I will tell you now in details. So the incidence is unknown. According to the physiology of the problem, the normally at rest, as we know, that there's the muscle is the puborectalis muscle, which performs the anorectal angle as a mechanism of continence. And during normal defecation, there must be an impulse from the brain to the sacral center in the spinal cord through pudendal nerve to the puborectalis muscle to relax this muscle, so the anorectal angle relaxes obtuse to help relaxation of pelvic floor during defecation, to empty a large amount of stool without any effort and without any pain. And it's also the muscle, there's a tone on this muscle and squeeze to help the fecal continence. And this is with the aid of pudendal nerve, which is very important because it gave the sensory innervation to the person, the human being, to have the sensation to defecate, the motor motion, which is voluntary control for continence or to relax during defecation, and autonomic, which is conscious awareness of the need to defecate, which is the desire. Importance of pelvic floor muscles, levator ani and puborectalis. Puborectalis during defecation, its function is to relax during straining, and pelvic floor muscles, levator ani, must be strong enough to hold the rectum to help the normal defecation in a coordinated, integrated manner to maintain proper defecation, to empty a large amount without pain in a limited time without effort. We are now talking about our topic, the pathogenesis of this obstructed defecation. It's a multifactorial problem. There's problem in these muscles physiology, in the relaxation of the muscle, with the problem in the nerve, pudendal nerve, and there are some precipitating factors like the elderly and old age. I will tell you now about the details, and with the different presentations to this condition of obstructed defecation. It's not only in the bowel. It can be in a form of overflow fecal incontinence or obstructed defecation, in a bladder disorders due to perineum descent, which can leading to urinary incontinence or retention, and when there's cystocele due to incomplete emptying of urine, sexual dysfunction due to pudendal neuropathy, and weakness of pelvic floor muscles, like in males, erectile dysfunctions, or in females, dyspareunia due to the presence of rectocele and cystocele, which can lead to narrowing of the vagina. And we have chronic pelvic pain syndromes due to like vulvodynia, proctalgia fugax due to pain through the pudendal nerve branches. The program of pelvic floor rehabilitation is very important. It starts very important, and the basic is diagnosis and assessment, and then health education, because it's a new type of medication or management here in our countries, Arab countries, and therapeutic exercises, which is the main cornerstone at home, to practice at home because it's active exercises, and physical modalities, which is my specialty. I will tell you about the modalities in details. According to the history taking and examination, very important to know the problem in the patient. If the problem in the urinary, in the fecal, I have to ask the time of the toilet, the amount, color, the smell, according if it's offensive smell, according to the time of the toilet, the straining, the effort, according to the urinary, if it's correlated problems, about sexual problems, if correlated pain in the genital or perineal area, and then come the examination. According to my specialty, my role in examination is to assess the process of isolation of pelvic floor contraction. I mean that I have to know if the patient can contract, isolate pelvic floor contraction, can perform isolated contraction without usage of accessory muscles like abdominal and thigh or buttocks or no. And then to assess the strength, because if the muscles during digital examination, anal or vaginal, according to the problem, and the classification, because if the muscle is less than grade 3, according to modified Oxford, and there's no ability to contract, very, very weak, so the patient cannot be able to benefit from our rehabilitation program, because he must be active during the exercise program. According to the values which are important to measure during the assessment, at the baseline assessment is measuring of the anal squeeze pressure, which is very important, and also the measurement of the maximal time of holding maximal contraction, the flex number of fast contractions, and endurance, which is the measurement for the slow muscle fibers. How long can the patient maintain submaximal contractions in a duration about 1 minute? And we have also the electrophysiology, which is through measurement of pudendal nerve conduction through sun mark, and we have also needle EMG. Pelvic floor physiology is important to be able to identify if the problem is in the nerve alone, it's the nerve, or in the muscle, to be able to tell the patient about the pathophysiology and the prognosis. If the patient will improve as soon as possible and fast with the rehabilitation, or he needs time, or there's poor prognosis according to the condition. According to the education, it starts with the patient with identification before starting sessions about the anatomy, physiology of the bladder and the bowel, about what is the type of the modalities, if there's pain or no, if the patient will be nagged or he will be using his clothes, we can use the devices and the physical modalities according to the duration for these modalities. Also, it's important the lifestyle modifications. We have to avoid for the patients with perineum descent, lifting heavy objects, straining, because this is important, and about also healthy diet, which is very important, about eating, about drinking, avoidance of large amounts of carbohydrates, especially in dinner. It's very important. It's important with a high fiber diet to help this patient. According to bearing, as I said, it's important to avoid. According to sex with obstructed defecation, some indications and precautions can be given to the patient to empty before sexual intercourse to avoid pain and suffering dyspareunia, especially in females during sexual intercourse. And proper toileting position with the Arab toilet, which is what it was all with the angle of 35 or 34, which is ideal. The knees is high from the hip to help the complete evacuation with relaxation of the pelvic floor for a large amount of stool with a minimal effort. According to the exercise, Kegel exercises is very important. It's not only important to diseased, unhealthy, also to healthy individuals to practice Kegel exercises to these muscles, which is very important to perform correct muscles as a very important step to achieve the pistol training effect. According to the modalities, it's very important, as we know, the essential device is the biofeedback. Biofeedback is a behavioral treatment. It's like a computer screen to help the patient to assess and to can see and visualize, and also other auditory signals, the contractions and relaxations of his pelvic floor muscles to be recorded, and the patient can, from this device, train himself how to check the performance of correct pelvic floor muscles contraction, which can be in a computer screen as electrophysiological, physical, or as a pressure responses or photos. Because many researchers found that the patient with a verbal or written instructions, only 26 can learn and perform correct pelvic floor muscles contractions. And performing of incorrect can lead to pelvic pain and fatigue and worsening of symptoms. So important to use biofeedback as a very important physical modality as a bridge. It increased the motivation and awareness to patients with pelvic floor problems to help them to isolate pelvic floor muscles contractions and relaxations. To know, we have sessions, the types. There are two types, manometric or electromyographic biofeedback. Manometric, we can use anal pressure sensors in these patients who are suffering from obstructed defecation. And when they have problems vagina, they will use the vagina when they are married. And we have also the electromyographic using the pen, the anal probes. The types of the sessions, we have double channel and single channel. Double channel, the patient with two channels, one from the accessory muscle and the other is from the pelvic floor. And the patient with a trial and error can learn how to correct contraction to the pelvic floor muscle and relax this accessory muscle. And from this step, we can start the second step for the single channel. We start to help the patient to relax the pelvic floor muscle during the anesmos, during contraction, during defecation. The patient how to relax in spite of contraction to help the defecation. And then when there's perineum descent, erectocele and cystocele and uterine descent, we can use the additional session for strengthening of pelvic floor muscles. We can here see this graph. The graph here up, we can see that the patient have two graphs where muscles are contracting simultaneously together parallelly, the pelvic floor and the abdomen, and this is wrong. After 2 sessions from biofeedback, the patient learned how to contract only pelvic floor muscles without the usage of the abdominal muscles. And this is the step to train the patient. To start the relaxation, what is a relaxation session? Relaxation session, the patient is sitting in a toileting position and the device is using the anal to simulate the real situation of defecation. And we ask the patient to defecate and try to relax pelvic floor muscles, the contracted, spastic pelvic floor muscles, and this without without seeing this graph, which is from the pelvic floor muscles, it's relaxed, and without hearing the voice from the sound from the device. For example, here, this patient is defecating, and there's a spasm, there's anesmos, there's contraction of pelvic floor muscles. There are very poor relaxation. The pressure is around 50. And here down the graph, when the patient usage of 5 sessions of biofeedback, how she can relax pelvic floor muscles is around 0 during defecation. They teach how to relax during defecation in spite of contraction. The sessions is take long time. It's about up to 45 minutes. It's time consuming, of course. It needs very good communication between the patient and the doctor. It's customized to each patient according to his condition. Some patients are need the endurance exercises, some flex, some are using the relaxation, some relaxation, and also the strengthening only. And the sessions can be repeated as reinforcement up to the improvement of the patient after 6 weeks, 6 months, 6 months, 12 months, to the additional benefit to these patients. Success of biofeedback depends on compliance to these sessions and practicing of therapeutic home exercises. And this can happen with a very good doctor-patient relationship. If biofeedback sessions are effective alone? Of course, no. We need exercises at home, as I said, lifestyle modifications, and we need also another devices like electrotherapy or like the very important, the also electromagnetic. Electrotherapy in a form of electrical stimulation. Interferential is an old way, but still used sometimes, and the patients use it at home. And we can use also posterior tibial neuromodulation, which can be used to relax the anesmos. According to electrotherapy, we have stimulation to the nerve through electrical stimulation TENS device to relax the muscles, to make duplication of sensation with special parameters, or we can use also interferential to strengthen pelvic floor muscles when we have a problem in the patient, to use biofeedback or as a simultaneously additional way to increase the duplication for the response. And we have also posterior tibial neuromodulation, in which we can put the electrodes in the patient in the posterior tibial nerve to help relaxation as a form of neuromodulation to relax the muscles during defecation. As a theory, as a form now, there are the more advanced, of course, the sacral neuromodulation, but still used till now in our country, the posterior tibial neuromodulation. My message in this lecture that we don't have to let this patient to suffer in silence, and it's not recommended to do surgery, especially in mild and moderate cases. We can do post-operative rehabilitation, of course, for severe cases, and in mild to moderate cases, we can do pelvic floor rehabilitation to open head and close doors to help improvement for these patients in their life without suffering. And thank you.